All right, so the last of our three talks and kind of really following the journey of HD across a lifespan is in talking about the impact of chorea in HD. So we just talked about the non-motor symptoms of HD. Now we're going to talk about the motor symptoms of HD and specifically spend some time talking about the impact of chorea and the evolving treatment landscape. First, we will have our patient and care partner, the same one that we've been talking with this time, talk a little bit about their experiences with the motor symptoms, specifically the chorea, and how it's impacted his life and their family. All right, welcome back to part 3 of our discussion on HD. We're joined again by Mr. and Mrs. Duggar. Thank you for joining us for our discussion today.
Thank you.
In this next section, we're going to talk about the impact of the chorea, the abnormal involuntary movements. And the first question I'd like to throw out there is, chorea is technically an involuntary movement, right? A movement that you do not have voluntary control over, but the movements can involve different parts of your body. And because of that, how have you noticed that your chorea affects other voluntary movements that you do, such as speech and swallowing, if it's in your mouth area, or use of your hands? I know we talked about you're working on this classic car, so fine motor skills with your hands and things like walking and balance. Walk me through some of those.
I have trouble. I have trouble with speech. A lot of times I have to repeat things to my friends at these club meetings and stuff like that. And I still have trouble with swallowing every day, every single day. As far as my walking goes, I think my walking's pretty good, thanks to the treatment.
Yes. He actually, the hand movement, is quite intense at times. He needs some help with his medication and, of course, with foods and things like that. But he showers himself, does all that kind of, things he needs to do alone. He does that himself. So that's great. I am here when he gets in the shower and he gets out just to make sure, because he did have a slip and fall in the shower. So he's afraid now I have to be here, he's in the shower. So we do make sure that's going on. But as far as every day, I think he does a great job.
And we talked about in the last section that your psychiatric and cognitive symptoms are pretty mild. So would you say that your dominant symptoms of your HD are the motor symptoms, these physical symptoms?
Yes, I would.
Yes.
Okay.
Because the walking, like you're in a restaurant and you need to sit down. Sometimes restaurant floors are slippery and chairs slide. So we try to get a booth for us to sit in, but however, I still have to hold onto his arm when he sits down and then stands back up just to keep from sliding down. Yeah, no high tops on tables. That's just a no-no.
And you hinted at it, Mr. Duggar, that that the movements actually are better with treatment. So tell me about that. When we started to treat your chorea with medications, how much improvement in your overall daily function did you experience?
Oh, I had a great deal of improvement, completely from the treatment, completely.
So it was enough improvement that you could tell, an improvement once the medicine started to kick in?
Yes, sir, I could.
Okay. And then over time, we've adjusted your dose, right, to try to stay on top of it. What has been your experience with that? How your chorea and the treatments have kind of evolved over time?
He was a little hesitant, like when the medication dosage would be increased, just because. But after he would start taking it, and after a few weeks, he was like, well, yeah, I guess it did need to go up, kind of thing. So it's always a little fear factor, like, is it going up because I'm getting worse? Is it going up to make me better or make me worse? It's always a big question mark there. But by and large, he's done well with the medication. No complications with it, no side effects at all.
So that actually helps in your willingness? I get it, because every time we go up on the dose, oh no, that means my disease is worse. And Sheila, you hinted at it, that sometimes there's fear of, well, if we go up, are we going to start getting side effects, things like that. But thus far, even though you're kind of on a moderate dose of medication, no major side effects from the medications. Is that correct?
No.
No side effects at all from day one till today.
Okay. So really no side effects, only benefits, which that's kind of nice, right?
Exactly.
Absolutely.
Exactly.
Okay. And what about receiving the medication on time? The logistics of getting your medication. How has that process been? Overall smooth or not smooth?
Very smooth.
It's been very smooth. We're called about a couple of days before it's actually time for them to ship it out. They verify how many pills he has left, verify the address with us, and they ship it out. We know it's going to be here the next day between this time and that time, so it works great for us.
Okay. Have you ever accidentally run out of your medicine to see what your chorea would be like off your medicine?
No way.
Okay.
No, I make sure that I count those pills every month. No.
Okay. And because you had improvement, you don't want to see what it's like without it, right?
No, sir.
No.
Okay. Well, that's a good sign. That's a good sign. And then overall, how do you feel like your chorea is controlled now on your current regimen?
Very well.
Okay.
Very well.
So you feel pretty confident in the treatment options or the treatment that you're taking. And you feel like it's really helped you.
I do. Yes, sir.
Okay. Lastly, what would you say so some people would say that getting the medicines for chorea for HD patients is a lot of hassle and they're expensive, and patients may not even notice the chorea. So a lot of times doctors will not treat an HD patient's chorea. What would you say to someone who's afraid to treat an HD person's chorea?
The very first time that we met you told us, you said, Tom, this is not your mother's diagnosis. This is not your mother's Huntington's. It's come a long way. And obviously it has, because his mother and his mother's mother didn't have the option to take the medication that he has the luxury to have. So he knows firsthand, up close and personal, the effects of not having the medication. So therefore, he chooses to have it, and we're choosing our path here to be a low-key, hopefully, no issues like his mom.
I was 12 years old when she first was diagnosed with Huntington's, and on my high school graduation, she was in a wheelchair.
So you saw progression and treatments actually making things worse, maybe than better, but you've not experienced negative side effects of our modern treatments.
No negative side effects at all positive, just positive.
Okay. So you'd encourage maybe a doctor who's hesitant to treat the chorea to go ahead and do it because you've seen such positive results yourself.
Absolutely. Absolutely.
Okay. Thank you so much for joining us today.
Thank you.
And a big thank you to my patient and his wife for discussing all of these impacts throughout these 3 talks. And I greatly appreciate their willingness to share their story with you. So now let's break that down a little bit more, and we'll get into kind of the functional impact of chorea. Hopefully the videos and some of the things that we've talked about with chorea, it's pretty obvious that though chorea is an involuntary movement, it has impact on all voluntary movements as well. And that impact will then secondarily have impact on their ability to perform all their activities of daily living, their instrumental activities of daily living as well. And then the point to make here is that the development of chorea is insidious and kind of over time, right? They develop this chorea to slowly and progressively over many years, right? So it's not easy to notice something that's developed slowly over time, combined with this disease unawareness that Mr. Williams had talked about it when we talked about these non-motor symptoms, this anosognosia. So they're a little unaware and it's developed really slowly over time. That combination may cause the patient not to desire any treatment for chorea unless the functional impact is pointed out to them. This happens to me all the time. Patient has tons of chorea. Obviously, I notice it because I'm looking for it and it's my first time seeing them, but it's developed over time and they might be a little bit aware of it, but they've just kind of navigated around it. So they kind of are like, well, it's fine. Yeah, I have all this movements, but it's fine. It's a little bit cosmetic, but I don't mind. And they're not interested in treating it just for the cosmetic aspects. But then when I point out, but we just talked about, you spill things, drop things, you stub your toe, you have some slurred speech and people ask you to repeat yourself. What about those things? Do those things bother you? And then they'll say, well, yeah, those things kind of bother me. Well, what if we could treat and get those things to be better? And then they'll say like, oh, okay, maybe it's worth treating for those reasons, right? So just to point out here that you as the clinician may recognize this better and don't just take a patient saying like, I don't really want to treat it as an excuse to not treat it for multiple reasons. And one is that we have good treatments, right? And hopefully by the end of this talk, you will see this, or I will have convinced you of that more clearly, that we have good treatments for this. So this is just, again, emphasizing the chorea in the different areas of the body that can have significant functional impact. So it's not just me convincing you. I'm going to now try to use some data to convince you. I have a series of published research here that will quantify the impact of HD chorea on a patient's life. So this first study is really looking at the impact of chorea and falls. So as we've talked about, and as I showed in the video, chorea in the trunk can lead to postural sway and cause patients to fall. So in this study, there were 45 patients with early to mid-stage HD, and 60% of them reported greater than 2 falls in the past year. And this, remember, is early to mid-stage, right? And you would think falls and things like that would be more common in mid to late HD, but this is an early to mid-stage. Over half the patients in the study were reporting more than 2 falls a year, which is a lot, and then 20% experienced a fall in the 3 months of the prospective follow-up of the study. Their Unified Huntington's Disease Rating Scales items for gait, chorea, and bradykinesia were higher in patients with falls, even after correcting for the disease severity, meaning that when chorea was higher, then they had more problems with gait and falls. So there was also a strong correlation between lower cognitive performance and higher degrees of aggression in patients with falls in HD. So I think we all know this. Mr. Williams in the long-term care facility space can tell you there is a huge emphasis on falls and fall prevention. And if you look at this numbers here, incidence of fall or fracture in patients with HD is 13.2 per 100, which is extremely high. And obviously we know that falls can lead to injuries, which affect ambulation, can precipitate admission to long-term care facilities. So, and so many reasons, we really want to prevent falls as much as possible. And this is a big one, right? Well, if they're tripping and falling, then the chorea is not just cosmetic, right? There's a significant functional impact there, and if they're having that, we should treat the chorea. What about chorea on other areas? Clumsiness, incoordination can lead to decreases in job performance and even loss of employment. I had a patient who was a mechanic, and he didn't have that much chorea, but he had enough chorea that as a mechanic, it caused him to fumble with some of these small engine parts. And then the critical point, he never really wanted his chorea treated. And his chorea, he had always rated it as kind of mild. But he dropped an engine block at work and cracked it. And it was going to cost his shop like 10 grand. Now, all of a sudden, he's at threat of losing his job. Now he wants his Chorea treated. Does that make sense? So, and then loss of employment and all the things emotionally and loss of independence that go with that, we go on a downward spiral and can have really significant consequences. So we want to kind of head that off if we possibly can. This is a study by my friend and colleague, Daniel Clausen at Vanderbilt, talking about the impact of Chorea on employment and self-care. And the bottom line is that patients with Chorea in HD compared to patients with HD who had less Chorea, right? So the patients with Chorea had more frequently required aid to help them get around, more frequently required modifications to their home, and more frequently required assistance in their self-care activities, right? So I think this is, data to show something that is fairly logical if you think about it. But just to know when we looked at data, it also backs that up as well. This was the quantification of that specifically, right? So again, this is patients with Chorea compared to patients without. All these patients had HD. So they're more likely to be on long-term sick leave, retired or unemployed, less likely to be employed full-time, more likely to be on long-term sick leave, working less frequently due to worsening of cognitive symptoms as well, working less frequently due to onset of the motor symptoms, not working due to difficulties with completing everyday tasks, and still working but requiring more frequent changes to their workplace. All of those much worse in patients with Chorea versus HD patients that didn't have Chorea. Obviously, patients with HD patients without Chorea still had some impairments in some of these areas, but if you look at these were statistically significant differences between the two groups. Mm-hmm. And then the other thing that we've been talking about, that obviously if you impair these things, it will also impact quality of life, not just for the patient, but the caregivers as well. So this study is really showing that when a patient with HD has Chorea, and the things that happen to them from that it actually has a negative impact on the quality of life of the caregiver as well, right? So the big themes that were found were that there was increased need for levels of support. They had difficulty with access to that, felt let down by the system. They had these feelings of loss of relationships, so their emotional well-being was less. Some practical aspects of caregiving were more challenging, like lack of appropriate care facilities and education, lack of time, increased exhaustion, and their dissatisfaction with their caregiving role, right? I mean, you got to remember, these caregivers, they know what they're signing up for in this familial disease that has impacted multiple generations. They've probably seen it in other areas. And despite that, patients with more Chorea, and it led to quality of life issues for the caregivers as well. And this is one showing that the patients themselves had decrease in their reports in all the health-related quality of life outcome measures when they had significant Chorea. This is showing that numerically, patients with high Chorea scores had a higher degree of anxiety, higher degree of social stigma, lower amounts of positive affect and well-being, and less desire to participate in their medical decision-making. So hopefully, with the things that I've discussed, both anecdotally and with evidence, we've illustrated that Chorea has significant impact on a patient and a caregiver's quality of life and function. And so therefore, even if a patient does not report that their Chorea bothers them, that there's lots of evidence to suggest that if we dig a little deeper, that it does bother them or has impact. And this is the opportunity for us as clinicians to step in on behalf of our patients and their families to really intervene with treatments that we have. So what treatments do we have? right? Let's talk about our chorea treatment landscape, and what, if we're going to offer things to them, what do we have? And I think if we're talking about what do we have as far as managing chorea, it's fairly simple. There's three big categories. The categories are your FDA-approved VMAT2 inhibitors, your off-label medications primarily are going to be antipsychotic medications, and some others. And then non-medical approaches, right? So pharmacologic approaches, we have two groups, the VMAT2 inhibitors, and then everything else, and then your non-pharmacologic treatment options. So let's go through that. And I think understanding how these pharmacologic treatment options work, we can do not too much, but just a little bit of a dive into the pathophysiology of chorea in HD. Where we think the chorea in HD comes from, we talked about already in the first talk that you lose these medium spiny neurons in the striatum disproportionately in HD. And when you lose those, you get excessive dopamine release. I'm not going to revisit the whole direct and indirect pathways that many of you learned in medical school, but suffice it to say, this excess dopamine will suppress the glutamatergic input of the indirect pathway, and then you get less no-go, which means more go or more movement in general, and that excess movement manifests as chorea. So if there's excess dopamine leading to excess movement, then we really have two ways of addressing that pharmacologically, right? So if the pathophysiology leads to excess dopamine output, and that excess dopamine output is causing the involuntary movements through these different pathways that we know about, then we can decrease that dopaminergic output in one of two ways, right? Either we inhibit presynaptic dopamine release, right? Or we block the postsynaptic dopamine receptors. Those are our two primary ways to affect dopamine. And if those are our two primary ways, we just talked about there's two pharmacologic categories, right? So first we have our VMAT2 inhibitors. There are three of them. And our VMAT2 inhibitors prevent or decrease presynaptic release of dopamine. And so the figure on the right illustrates where the action is, and you see that arrow for VMAT2 is in the presynaptic terminal. And if you inhibit VMAT2, then you'll have decreased dopamine release. It's fundamentally different than antipsychotic use off-label. And so if you know much about antipsychotics, you know that there are typical antipsychotics and atypical antipsychotics. The atypical antipsychotics are called that because they have more than just dopamine as their mechanism of action. But many atypicals still have dopamine receptor blockade as a feature. They just also have serotonin and other activities as well. But because of that, both atypicals and typicals, their mechanism for suppressing chorea is through binding and blocking that postsynaptic dopamine receptor. Now, the problem or the main differences there are that if you block the postsynaptic dopamine receptor, even if dopamine comes into the cleft, it can't activate normally because there's no receptors to bind, right? Whereas we generally think of the VMAT2 inhibitors as a little bit more gentle because they decrease dopamine release, right, into the cleft. But if dopamine still comes in through other neurons, or it's not decreased down to zero, it's still having some dopamine. It can still bind the receptor and activate for normal movements, right? Whereas postsynaptic blockade tends to be more abrupt and can cause receptor remodeling and these kinds of things as well. So those are those. And the VMAT2 inhibitors, the timeliness of this talk, if you're following press releases, valbenazine was actually just approved last month, actually, for the treatment of chorea in HD. Been on the market for other forms of chorea, but specifically in HD, FDA approved in just last month, whereas tetrabenazine, deutetrabenazine have been available a little bit longer. All right, so let's do a little bit of a dive into the data for each of these things. The data is primarily on your FDA-approved drugs, right? Obviously, the antipsychotics are not FDA approved because of their lack of data, not because pharmacologically we don't think that they would work, but since there's been no rigorous, standardized, double-blind, placebo-controlled trials, we don't have FDA approval for those. But for the ones we do, let's talk about the data. Tetra HD was a trial for tetrabenazine in HD. Tetrabenazine been available in the US and around the globe since the 1970s, but wasn't really tested in HD in a rigorous way until the early 2000s. In that trial, they showed a significant reduction in the total maximal chorea score for tetrabenazine versus placebo, which is tetrabenazine is the blue line here, and you see there's a significant improvement in chorea that then washed out once the patients stopped taking it and they returned back to where the placebo group was. The dosing for tetrabenazine in the trial was about 75 milligrams per day divided between BID to TID dosing. The average dose in clinical practice, though, we found to be closer to 50 milligrams per day. And that's felt to be dose limitation due to adverse effects. If you look at the AE rates, and this is again reported in the original pivotal trial for this disease, very high. So the sedation and somnolence, 31%, insomnia, 22%, depression and suicidal ideation, 19%, akathisia, 19%, Parkinsonism, 18%. These are very high numbers, higher than most drugs that you probably prescribe on a day-to-day basis. There was one completed suicide in the treated arm, and that combined with what we saw in the data that 19% of patients reported significant worsening of depression or emergence of suicidal ideation, it led to a black box warning for depression and suicidality for this drug. If you're interested in it or just for an interesting read, go back and read the original FDA approval letter for tetrabenazine that the FDA put out. It's interesting. They basically said, man, we see all these AEs, but since we've got nothing else for HD, we'll approve it. But it's an interesting letter. And I think and understanding that data and where that comes from also will help you to view our novel VMAT2 inhibitors in a different light. So what is deutetrabenazine? Deutetrabenazine, they did deuterium substitution for hydrogen in two key places in the CYP2D6 binding domain of the parent tetrabenazine molecule. And what that does is deuterium's a little bit heavier, right? And so it requires more ATP to go in to cleave that bond. And so you create this kind of in vivo extended release. And when you do that, you can lead to a lower Cmax, but in a similar area under the curve. With less drug exposure. And the doses for deutetrabenazine are about half of what the daily doses are for tetrabenazine. So when you have less exposure, less drug exposure total, but similar area under the curve, then what that allowed is efficacy. It reduced chorea, much like tetrabenazine did. And the numbers are pretty similar, but there's a significant improvement in the adverse event profile. So looking at a lot of the same adverse events, right? Sedation and somnolence, instead of 31%, we're at 11%. And I think that's a lot more palatable. Depression and suicidal ideation, instead of 19%, we are at 4%, right? So this is just much more favorable. Deutetrabenazine is dosed at 48 milligrams per day. The traditional deutetrabenazine is dosed BID. So instead of BID or TID, it's BID. Although a once daily extended release version of deutetrabenazine did become available earlier this year. So now we have the same efficacy and side effect profile in a once daily version. And then our other novel VMAT2 inhibitor, which was just approved, is valbenazine for HD chorea. Valbenazine is a purified prodrug of the active alpha metabolite of tetrabenazine. So since it's a prodrug, and the prodrug and the metabolite itself both will bind to VMAT2. But by doing this, it allows this longer half-life, and just like deutetrabenazine, similar area under the curve as tetrabenazine with a lower Cmax. So we should expect something very similar to deutetrabenazine, and in fact, we did with the pivotal trial, which is significant reduction in the Chorea score versus placebo, so efficacy is also there. And similarly to deutetrabenazine, a significantly reduced AE profile compared to tetrabenazine itself. It's dosed between 40 and 80 milligrams, and it's once a day. So the novel VMAT2 inhibitors, I just wanted to make a point about them, that both deutetrabenazine and valbenazine show similar efficacy to tetrabenazine, but have far superior tolerability. And because of that, I mean, this is a big soapbox of mine. A lot of people that have used just tetrabenazine for a while, because of the reasons that we showed you with the data, there's a lot of AEs with it. And they view the novel VMAT2 inhibitors as just extended release tetrabenazine. And then in their minds, they say like, well, if tetrabenazine is bad as far from an AE profile standpoint, why would I want to expose my patients to more of the bad by doing an extended release? But if look at the data, the AE profile is much better and much more tolerable, and it gives these unique differences between tetrabenazine and the novel VMAT2 inhibitors. And even though there are no head-to-head data, because the studies are similar in their size and their design, it does allow for some indirect comparison. So I've made a summary table in the next slide that we'll go through. This is just to say, from comparing deutetrabenazine to tetrabenazine first, there was even though there wasn't a head-to-head trial, there was this trial called ARC-SWITCH, where the same patients overnight switched from tetrabenazine to deutetrabenazine. So that's about as close as you can get to a head-to-head, right? The same patient took both drugs. And we looked at what happened. And patients were allowed to have titration. And because the tolerability was better, they were actually able to tolerate up to a higher dose of deutetrabenazine than is the currently listed FDA-reported maximum. And their chorea control after the switch was better than upon entry into the study. But if you think about, like, why is that the case? Well, the efficacy numbers were the same between tetrabenazine and deutetrabenazine. But what's different that we already talked about? Well, tolerability is better. If tolerability is better, and remember we showed the data that tetrabenazine real-world dosing is actually less than the pivotal trial due to efficacy, well, then maybe real-world dosing for both of these drugs, patients can tolerate more deutetrabenazine and maybe get a little bit more efficacy because of that, maybe, okay? So how do we compare these? And again, this is not published, but this is just me making a table of some key features of the 3 VMAT2 inhibitors that we have available. Half-lives listed there. You have short for tetrabenazine, medium for deutetrabenazine, and long for valbenazine. And then the recommended dosing. And then the pill formulations, there's some slight differences there. And efficacy we have listed there. And then the AE profiles listed, right? So going through the table. So if you notice, some of these numbers are a little bit different than I had in the previous slides, but the differences are because now I've taken drug and subtracted placebo. So the numbers here for the AEs are the differences between drug and placebo, right? So remember that the absolute number for sedation and somnolence for tetrabenazine was 31%, but the treatment difference of drug versus placebo is 28%, still dramatically high. So now if we're looking at treatment differences between drug and placebo on sedation and somnolence, right? Tetrabenazine 28%, deutetrabenazine 7%, and valbenazine 13%. So, that's a big one, and a lot less. And then depression, 20% is the treatment difference in tetrabenazine, And when you now subtract out placebo for both deutetrabenazine and valbenazine, notice that both goes away, right? Because depression and suicidality, as Mr. Williams just discussed, very common in HD itself. And when you subtract out the depression and suicidality reported in the placebo patients, now there's no difference between deutetrabenazine and valbenazine versus placebo. So I think that's an important feature to mention, and scares people away from VMAT2 inhibitors, because what we just talked about, depression, suicidality, unfortunately very common and problematic in HD. Well, do we want to give a drug that could make it worse? But if you look at the data of the three, the one that really statistically makes it worse is going to be tetrabenazine, really less so. Pharmacologically, is it possible with deutetrabenazine and valbenazine? Certainly, but at least in the pivotal trials was not seen. Cost is high for all of these drugs. If you look at the costs there, they're listed at the bottom, very high. But one of the things I wanted to point out in real world use is related to the last item on the table, which is there a patient assistance program, right? So in my mind, the problem with a very expensive, thousands of dollars a month generic with no patient assistance program, is that I think about, just like we were talking about real world efficacy, we can talk about real world cost, right? So I care about cost to my patient, and a generic that doesn't have a patient assistance program could be thousands of dollars a month versus a branded that, yes, by absolute cost is more, but has a patient assistance program. Often these branded drugs with patient assistance programs may be cheaper per month to my patient than the generic, which is interesting. And then we already talked about there's real differences between the generic tetrabenazine and deutetrabenazine and valbenazine, especially with the AE profile. Okay, other VMAT2 inhibitor considerations. They all have black box warnings, but deutetrabenazine and valbenazine, their black box warning is a class warning only, for the reasons that I just showed you with the data. But there is a black box warning for a class of drugs, because pharmacologically it can cause that. But the black box warning for tetrabenazine was based on the data itself, and what we actually saw. Okay. And then the last point we already touched on with the table. All right, so that's the VMAT2 inhibitors. What about neuroleptics and antipsychotics? Because those are widely used as well. So why are they widely used? They can have this dual effect, right? We just talked about the non-motor symptoms in HD. Maybe you use an antipsychotic to treat non-motor features of HD and also get the effect of treating the chorea as well. So certainly that is a reasonable thing to do. The other thing is that antipsychotics, for the most part, are going to be cheaper than any of the VMAT2 inhibitors. So maybe there's a cost-related thing too. So the only downside is, yes, if there are dual things that you want to treat, like psychosis and chorea, you can use an antipsychotic to treat both. But maybe, especially if you're thinking about using tetrabenazine, if they have depression, the depression may be a contraindication for VMAT2 inhibitors, but you can use a antipsychotic to treat both, right? We talked about some of the atypicals in particular have a lot of serotonin activity, and are used in refractory depression. So maybe you kind of hit two birds with one stone. But due to this anecdotal use, it has been studied to small degrees. We do have some studies that show, and the study cited at the bottom, that antipsychotic use in HD has been associated with a faster functional decline. We don't really know why, but maybe it's related to worsening of the bradykinesia, slowing of their voluntary movements, maybe causing some dystonia. Hard to say, but those were the things that were kind of postulated in that study cited at the bottom. The other thing is that the doses that are required to control the chorea, often, if you know about the pathways of dopamine in the brain, the behavioral effects of the antipsychotics are primarily through the mesolimbic kind of pathways, and the motor effects are through the nigrostriatal pathways for dopamine. But in order to cross over into the nigrostriatal pathways, sometimes the doses required for the antipsychotics are high to control the chorea, and that can lead to affective blunting. And affective blunting is a big word. Patients don't come in and say, Mr. Williams, I'm having affective blunting from my haloperidol. But what they say is their family members will, affective blunting, what we really see clinically is it looks like this zombie-like effect. And that can be problematic. What about other pharmacologic treatment options? Amantadine, benzodiazepines. Amantadine, most movement disorders neurologists are very familiar with using amantadine in the levodopa-induced dyskinesias of Parkinson's disease. So thought, well, that movement in a Parkinson's patient is fundamentally chorea. So could we use it off-label for the treatment of HD chorea? And some people do. And I think the tricky thing is that there are only two very small trials, one suggesting some small benefit at 400 milligrams per day, and another suggesting no benefit at 300 milligrams per day. So the general mantra is, if you're going to use amantadine, you can, but you'll need to try the higher doses, like 400 or higher. Benzodiazepines, they can suppress chorea as well, but obviously, given the sedation and other features that they have from a behavioral standpoint, they can increase risk of falls, but maybe use a benzodiazepine if they have a lot of anxiety to treat some of the anxiety, but also treat some of the chorea. All right, so there are formal treatment guidelines for HD chorea, although I will mention that they have some caveats. So the treatment guidelines for that were internationally published in the by the Movement Disorder Society show here that tetrabenazine and deutetrabenazine at the time, and again, this was prior to the FDA approval of valbenazine, but those have the strongest grade A established scientific proof and are recommended as first-line therapy. Whereas the antipsychotics, if you list there, so haloperidol is the one that they mentioned in the trial, is the one with the most evidence, but it was still graded as a grade C, low level of scientific proof, and they recommend it as a second-line treatment for HD chorea. So in the international treatment guidelines, they also had some other special considerations that they mentioned in the paper, which are when to consider therapy, evaluating the ongoing management, and then monotherapy versus combination therapy, and protective measures. So protective measures, Mr. Williams is going to discuss in non-pharmacologic strategies in upcoming slides. But I wanted to make a particular point here. If you look at what the treatment guidelines recommend, they said consider drug treatment if chorea causes distress or discomfort. That's what the wording that they used. But that's a little bit of a different line than we've been towing in our talks here, right? And I would push back a little bit on this. I would say that we should treat chorea before it causes actual distress or discomfort by the patient. Because for all the reasons that I just showed you, anecdotally and with data, many patients don't report a lot of distress or discomfort early with it, but they're actually having functional impairment in their life from the chorea. The thing that you have to know is most of the authors of these international treatment guidelines practice in an area where the novel VMAT2 inhibitors are not available to them. So the only available treatment options to them are antipsychotics and the original VMAT2 inhibitor, tetrabenazine, which, as we described, has significant limitations. So maybe that colors their recommendations for treatment because they don't feel like they have good treatments. But I would say for us stateside, having these novel VMAT2 inhibitors, they're good treatments with a low AE profile that maybe changes the way we approach this. All right, and then just some other things that they went into for treatment guidelines. You will have the slides and can go through this, but they discuss some of these AEs with VMAT2 inhibitors and some contraindications. They discuss the AEs with antipsychotics as well, and other relaxation therapies, which we'll get into. The American Academy of Neurology also has treatment guidelines for HD chorea, but look at the publication date, right? So this was in 2012. These have not been updated since 2012. None of the novel VMAT2 inhibitors that are available now were available back then. But even back then, when it was just tetrabenazine and the antipsychotics and other things available, they concluded that there was insufficient data to recommend antipsychotics for the treatment of HD chorea. So it's not even listed on their table. But they gave level B, probably effective evidence for tetrabenazine as the primary recommendation. All right, so what about the treatment landscape now? And we've talked about this already in this evolving treatment landscape. This talk is one of the first that I know of that's really going over the entire treatment landscape after the new approval, since the new approval for valbenazine was just last month. But as far as what I consider for the future, I'm hopeful that now with another novel VMAT2 inhibitor out there, that this competition will drive down the pricing. That's one of the primary negative things about the novel VMAT2 inhibitors. I think that we will see concomitant use of VMAT2 inhibitors and antipsychotics to increase over time. And if we do that, we will need to monitor the safety over that. And hopefully we'll be able to generate some data on the additive effects on sedation, Parkinsonism, QT prolongation, all of these things. But we'll see how this goes over time. And then would love to see some long-term safety and other real-world data on the novel VMAT2 inhibitors, since it is lacking currently. And then lastly, for the multiple reasons I described, I'd love to see update of the treatment guidelines to include all of our available therapies, particularly the AAN guidelines, which are over 10 years old now. So, we'll just have to see how that landscape evolves over time, but excited to see how that goes. And with that, I'll turn it over to Mr. Williams to kind of talk about some of our non-pharmacologic interventions for chorea.
Thank you, Dr. Sung. So one of those has been being that of speech therapy, using communication boards and some of our augmentative devices that our speech pathologists help us with, but ensuring that our patients also have safe swallowing techniques and recognizing that their swallowing can be affected. So speech therapy is an area. Occupational therapy, really coming into the home, ensuring that there's adaptations for the home, working with the tremor writing, and using some of their eating utensils can also help with the chorea. And then some exercises to improve coordination for our patients. And then lastly, that's a physical therapy, which especially is designed with rollators such as the U-step and exercises to improve balance and walking. I just want to highlight whether we're in the community, the patient is in a center of excellence, or again, if that patient is in that long-term care space, we always have these non-pharmacologic interventions that we can utilize. So not just that the patient is in the long-term care space, now these go away, but we want to ensure that actually in the long-term care space as well, that we're ensuring that these non-pharmacologic steps and intervention and resources, really, I like to call them, are available to our patients and being ordered by our clinicians. So it's not just the pharmacologic stuff that we are doing and the treatments there, but also ensuring that we're ordering these non-pharmacologic intervention and resources as well. Next is that of a high-calorie diet. So really, we see anecdotal that there's this evidence that weight gain can help dampen some of the chorea that our patients have. And then using relaxation therapies, whether it's art, yoga, there's aquatherapy, music therapy helps to improve coordination. And then using some padding on the floor, the bed, ensure that the patient also has some padding as well. Some safety precautions that we can use, removing the entanglements of cords, rugs, really doing an assessment of safety in the patient's space. And then utilizing the occupational therapist, the family, really to do multiple eyes, looking at the safety area, and then ensuring everybody is maintaining that level of safety for the patient as well.
And I think just as we think about and bring this back home, a lot of this is thinking a little bit outside of the box, right? So we're, thinking outside of the box a little bit with the pharmacologic treatments, right? I mean, many of the ones that we use, like the antipsychotics, are not even FDA approved. A lot of the non-pharmacologic interventions that Mr. Williams went through, they're maybe designed for other things. Like he mentioned, the tremor writing pens. Those are designed for people with tremor, but they actually will help people with chorea as well, right? So remember, HD patients don't have tremor, but we can give them a tremor pen if it helps them to write because their writing is interfered with chorea, like the patient that I showed you in the video. And the U-step walker, which many of you might be familiar with and prescribing for Parkinson's disease, is actually helpful for HD patients as well. So, these other things, just thinking outside of the box, using all of our tools that are available to us. And as Mr. Williams said, really the education, using the things that you already have. Long-term care facility patients are already thinking about padding of the floor, the bed, the patient for other reasons, removing entanglements. They're already doing this, but just making sure we apply this for patients with chorea as well. And how do we think outside of the box? We don't do it alone. We do it with a team. This broad impact of chorea on multiple aspects of a patient's life is more than any of us, myself or Mr. Williams, can manage alone. We do it together as a team. My physical therapist, occupational therapist, speech therapist, social worker, dietitian, they all come with their perspectives and give me and the patients recommendations to help manage their disease. And just as we mentioned in our previous talk, that even if no center of excellence is nearby and accessible, it's really important to prioritize this broader team-based approach to care. Some of this may feel redundant, that we're saying the same thing over and over again, but I hope you recognize if we say it over and over again, that's a key take-home point that we want you guys to have. So as far as our take-homes, the progressive physical impairment and loss of independence associated with HD, the chorea of HD in particular, poses a high burden for both patients and caregivers. And the available treatments for individuals with HD target specific symptoms such as chorea, but currently don't alter the course of the disease. And VMAT2 inhibitors should be considered first-line therapy for the treatment of HD chorea. And that antipsychotic or neuroleptic use is limited by both the lack of controlled trials, but could be considered first line in patients with concomitant psychiatric symptoms or if they have a contraindication to VMAT2 inhibitors. And with that, we will take any questions.
Well, welcome back to our Q&A for part 3, our final question and answer session. We have the wonderful privilege to have Mr. and Mrs. Duggar with us. So we're going to allow for them to answer some questions. Dr. Sung, I'll let you go ahead and start off with asking some questions.
All right. And then feel free to throw questions in the chat for Mr. and Mrs. Duggar. Kevin and I have fielded some questions already in the first 2 parts, so feel free to ask for anything from the patient perspective. I'm going to adapt some of the questions that have been asked for patient and caregiver perspective. So one question asked about how often we prescribe physical therapy for Huntington's disease. So Mr. and Mrs. Duggar, can you tell me like your experiences with physical therapy since your diagnosis of HD?
Well, you do recommend physical therapy, but Tom, being Tom, thinks he doesn't need to go to physical therapy. So, but he is out and about, going here and going there. We walk, we do things like that to try to keep the physical therapy, the physical part,
But
active.
that's not fair. I mean, I went to physical therapy for the swollen test and all that kind of stuff.
Yeah, he did go to physical therapy because he has a numb foot, along with the Huntington's, of course, from some surgery that went like it shouldn't have gone. So he went to physical therapy for that, and that kind of boosted him up a little bit more. So, yeah, as far as the physical therapy goes.
Okay. And what about physical therapy that you've received in the clinic when you come to the big multidisciplinary clinic? Like recommendations that they have for you, or things that any of that been helpful, or?
Oh, absolutely. Yes, definitely. And, and you always check the way he walks and stands and sits and things like this. And you recommend him doing exercises, which he does do. Your nurses recommend these sit and stand things, that kind of thing. So he does that here, and he does get out and about, and he has a walking stick that he uses. Depends on the terrain where we are. Sometimes a walking stick is good, but sometimes it's kind of in the way and a trip hazard. So we kind of pick and choose our battles there.
There's another question about nutritional guidance and swallowing difficulties. You mentioned having a swallowing test. So tell us a little bit about that, some swallowing difficulties you've had, your experiences with speech therapy, both in the clinic and outside the clinic, and any role that our nutritionist has played in giving you guys advice.
Oh, yeah. Everybody's great, and they're so informative on helping us out. And I have questions. I do call them, and they call me back, or they answer right away and answer any questions or concerns that I might have. And I did call and talk to the nutritionist or the speech therapist about Tom's speech. And so she recommended some different things in the swallowing. We talked to the nurses there, and they ordered a swallowing test, which we did go to one of the local hospitals here. And they did a swallow test and said it was perfectly fine. So we kind of adapted a little bit of different change here in our the way he takes his medication. We started, having him drink water ahead of time, and then take his pill. Instead of just taking the pill just straight with just the first sip of water to kind of get his throat kind of moist, and that helped a lot.
And so someone asked, are nutritionists part of the multidisciplinary team? They can be. Our nutritionist focuses a lot on gaining weight, just like other degenerative diseases like ALS and Huntington's disease is similar in that weight loss is correlated with increased functional decline. So we focus on maintaining or increasing weight, which seems kind of opposite to what we typically would think of, but
yes,
our nutritionists focus some on that. And then someone asked, do we refer our patients to PM&R? Not a lot. Because we have all the physical therapy, occupational therapy, speech therapy in clinic. If you don't have a multidisciplinary clinic and you're in private practice, then I would say then it would be the opposite. Then definitely you would, and then let a physiatrist kind of direct or guide the physical therapy, occupational therapy, speech therapy kinds of things. Because just as Mr. and Ms. Duggar said, it's not all about going to outpatient physical therapy. It's taking their recommendations and doing them at home, right? I mean, even if you went to physical therapy, going there a few times a week for 3 or 4 weeks, that's not going to provide you the same duration of benefit as continuing to do the exercises and staying active at home and staying safe and active at home.
Right.
Well, with our last minute remaining, Mr. and Mrs. Duggar, we'll allow for you to say some final comments before we close out.
Well, thanks for letting us be a part of your day. We've been really excited to get to be here. Tom and I have been married for 32 years. And, Huntington's, we didn't expect it. He was diagnosed when he turned 60, and we thought by the time he turned 60, we were home free from a Huntington's diagnosis, just from information that you read out there, but that was wrong. And so it was kind of like, there's no words to explain. There's no feeling that you can imagine how we felt, when that diagnosis came across. But it did. And so we've tried
Dr. Sung was a ray of hope, though.
Yeah, Dr. Sung, he's our hero. He's our guy. He told us, because Tom's mother had Huntington's, and so he knew from an early childhood and early age what it was like to take care of a parent and help take care of a parent who had it. And she died when she was in her 50s. So he told us it wasn't his mother's disease, and so we trust him, and it hasn't been so far. So we want another 32 years of being married.
That's right.
Awesome. Dr. Sung, final comments.
That's it. Thank you all for joining today. Thank you for your interest in Huntington's disease. And thank you again to the Duggars. There's a thank you in the comment in the chat to the Duggars for being here and for sharing your story. Thank you so much.
You're welcome.
Thank you.